going to now start the title slide. So, all right, you should see a black slide up there with blood pressure optimization for cardiovascular wellness. And that is the title of today's talk. So I'm going to go through quite a bit of the physiology, some of the biochemistry, and some of the different interactive effects that we have in our life on blood pressure regulation and cardiovascular wellness overall and cardiovascular sickness. But first, we're going to start with a little medical disclaimer for legal purposes. So any of the information that we present in this lecture is not intended as medical information. It's provided as an information resource only, and it's not to be used or relied on for any diagnostic or treatment purposes. This information should not be used as a substitute for a professional diagnosis and treatment from your care providers. Please consult with your healthcare provider before making any healthcare decisions for guidance about specific medical conditions that we talk about today in this lecture. And then for those of you that are practicing or, are coaches or whatever, just remember your scope of practice. Do not apply any of this information from the presentation that's outside your scope of practice. The presenter, myself, and PreCardix as a company hold no liability for actions taken as a result of attending this presentation. All right, so one thing that I recommend for everyone, especially as we age, is to measure your BP or your blood pressure regularly. And by regularly, I mean, I generally suggest at least weekly. A lot of my clients that are dealing with hypertension or even hypotension for that matter, I would tend to want them to measure it almost daily. So the more you can measure it, the more data you have on your cardiovascular homeostasis, and the better off you're going to be. Now, hypertension is found in 25 to 30% of the population of developed countries, and it's used as a conventional biomarker to increase cardiovascular risk. So it's a relatively easy measure to get, some good data out of. Now, hypertension affects over 972 million people worldwide, and it's been estimated that patients with hypertension will eventually account for 1.56 billion individuals by 2025. So it is a growing issue. Now, monitoring your blood pressure represents the most commonly used measure or procedure to diagnose hypertension. And the beauty of this is that you can easily and accurately measure your blood pressure at home with a few guidelines, which I'm going to cover in the next slide. But first, we should actually talk about what these numbers actually mean when we're talking about blood pressure numbers and knowing what they are. So what do these numbers mean? Well, when we're measuring our blood pressure, here we've got kind of a home blood pressure measurement device. The top number that we see here, 120, this is our systolic pressure. Now, this is the pressure that the heart, or more accurately, the left ventricle, must create in order to eject blood out of the aorta and into the peripheral circulation. You can think of this as the active ejection pressure. Now, the bottom number on here is 80 millimeters of mercury. This is the diastolic pressure. And this pressure is what the heart or the right ventricle fills at. It's the required pressure that it needs to fill at. So think of this as the resting filling pressure of the heart, or when the heart is not beating in between beats, it's filling up. And this takes 2/3 of every cardiac cycle. So the actual diastolic pressure represents the largest portion of the cardiac cycle. Now, this number 75 we got down on the bottom that shows on all blood pressure monitors. This is our resting heart rate when the blood pressure measurement was taken. In this case, this guy is sitting at 75. And if you see your heart rate elevated above, 70, 75, up around 80 to 90, then it's a pretty good sign that you're either under stress in this situation, which happens when we go to our physicians, and or you may have some sort of tachycardia or elevated heart rate. And we're going to learn today that when we have elevated heart rate, this can contribute to our cardiovascular hypertensive situations that we may be experiencing. Okay, so now that we know how to measure blood pressure, now we're going to talk some numbers. So let's discuss what these actual numbers are. So the normal blood pressure that we like to see as healthy or consider healthy is less than 120 millimeters of mercury. That's that upper number for systole. and less than 80 millimeters of mercury for the lower number, that's diastole. So 120 over 80 and less is generally thought of as a good normal blood pressure. And these are guidelines that have been taken from the American Heart Association most recently. Now, elevated blood pressure tends to be somewhere above 120-ish, and then less than 80 millimeters of mercury for a lower number. And generally, we're looking at the systole because that represents the highest pressure in the system, and that tends to be the pressure that drives most of our issues in our organs, which we'll talk about later on. So if you see your blood pressure under highly rested conditions up around 125, 126, 127 over around 80, then what you should be noting is what was your blood pressure back in the past, because elevated blood pressure over time becomes the biggest problem. So if you start to see slight elevations, it might be time to start taking a look at your lifestyle and whatnot. And I'm going to go through some definite actionables that you can utilize for getting through that. Now, high blood pressure or stage 1 hypertension starts around 130 millimeters of mercury for systole over 80 to 89 millimeters of mercury for diastole. And this is when we start to note where your physician would be saying, you want to keep an eye on your blood pressure. And a lot of the recommendations today will keep this circumvented from occurring. Now, once we start pushing at 140 millimeters of mercury of systolic pressure over 90 or higher diastolic pressure, then we're starting to get into stage 2 hypertension. And this is when we start to see some issues with our organs and especially with our heart if we let this prevail too long. And then finally, a hypertensive crisis. This is when, if you're in one of these, then you definitely want to call your doctor immediately or call 911. This is when we see blood pressures systolically above 180 and diastolically higher than 120 millimeters of mercury. And like I said, this is when you don't want to mess around with a hypertensive crisis. You want to either go to Emerge or contact your physician to find out what the next steps should be. Now, when we experience hypertension, like I said, we're going to get a number of different side effects of this, especially when we're pushing into these high blood pressures above 140 systole over 90. We start seeing ailments like stroke. We'll see vision loss. This, in a lot of cases, is actually your retina is detaching. Heart attack becomes an issue, along with heart failure. Kidney disease is a problem because the glomeruli in the kidney are very fragile and they don't like high pressures, especially high systolic pressures. And we can have some sexual dysfunction. So if you're experiencing any of this and you don't know what your blood pressure is, then I would suggest, any of these issues that you think you may be, feeling, especially if you have some kidney function problems or you're having some vision issues, definitely check your blood pressure and make sure that you've got it in check. All right, so now that we know what the numbers mean, how do we accurately and reliably measure blood pressure at home and in the clinic? And the reason why I'm saying at home and in the clinic is because a lot of times in the clinic, after I show you these little, ways to get accuracy, you're going to notice that there's a lot of mistakes made in the clinic. So you may want to correct them so you can get a good, accurate measurement before they start saying that, you're hypertensive or hypotensive. All right, so the first thing to do is make sure that they're using the right size blood pressure cuff. And you can tell by looking at the cuff, it'll give you the actual diameter, the circumference of the cuff based on the size of your arm. Now, if you don't know the size of your arm, you'll notice on the cuff that there's actually a little display on there to show you where it's going to accurately read when you put it on. You'll see a little line, it's a little solid line that you want the Velcro to kind of attach within. Make sure you got the right size cuff, because if you don't, then the machine is not going to give you the accurate result you're looking for. Do not eat or drink anything 30 minutes before you take your blood pressure. This is because digestion actually can be a stress. Swallowing is a stress, and your body will perceive that through its metabolism by increasing your heart rate at least. And when your heart rate goes up, as we'll learn in the next couple slides, then your blood pressure could go up. So you want to be in a fully resting state without having any food on board for the last 30 minutes. Empty your bladder before the measurement. This is really important because the bladder contains nerve endings that actually can increase sympathetic nerve activity This is your stress nervous system, and it will raise your blood pressure if you're sitting there kind of writhing in a little pain because you got to go take a pee. Make sure you're sitting comfortably in a chair with your back supported for at least 5 minutes before the measurement. This is a common one. You're kind of running late for your doctor's appointment. You rip in the front door, and then they have you sitting there, and then they're late for your appointment. You might be getting a little frustrated because you got to get to your next thing. And you all of a sudden they just throw a blood pressure cuff on you. This is going to give you an anomalous measurement. So make sure that you're comfy, you're relaxed before the measurement. And this generally takes about 5 minutes. Make sure your feet are both flat on the ground and keep your legs uncrossed, mainly so that you maintain the same posture every time you get the blood pressure measured. Make sure you rest your arm with the cuff on a table at chest height. And this is because you want your cuff to actually mimic the height of where the heart is. Because the cuff is the actual receiver of the pulses that it's going to be feeling, the pressures, then it's a surrogate for what's happening at your aorta in your heart. So you need the cuff at the same level as your heart. Otherwise, the biophysics of moving the cuff up or down will either decrease or increase the blood pressure measurement. So always keep it at your heart level. The cuff should be against your bare skin, not over clothing. This is a common one I see in the clinic, is where the physician or mainly the nurse will throw the blood pressure cuff on you. And if you don't have a short sleeve shirt on, then they'll pop it over top your shirt or even a hoodie for that matter. And you're not going to get a good measurement or at least an accurate measurement with this condition. And then finally, don't talk while you're taking your blood pressure for obvious reasons, but for some reason in the clinic, people like to talk to you. So just, you can ask them, hey, I'm trying to relax here and retake the blood pressure measurement, because like I said, these measures are very, very, very important. Okay, so in order for us to understand how to manage our cardiovascular wellness, we probably should understand something about the cardiovascular system. So the cardiovascular system, which is also known as our circulatory system, it's responsible for transporting blood, oxygen, nutrients, and waste products throughout the body. Now, the flow of blood through this cardiovascular system requires pressure, blood pressure, to circulate our 5 to 6 liters of blood volume optimally through a complex series of interconnected pathways and organs. And in this complicated diagram here, you can see that it's quite an extensive network. Now, these are only the macro vessels. These are the big ones. The micro vessels take up much more surface area than this. The micro vessels are what I study in my lab. Now, the process begins in the heart, where the blood pressure is developed by this muscular organ. And then this organ is divided into 4 chambers. In the heart, we have 2 atria. These are the upper chambers, and 2 ventricles, which are the lower chambers. The right side of the heart, which is going to be depicted on the left in our picture, it receives the deoxygenated blood from our body, and it pumps it to the lungs for reoxygenation. The left side of the heart, which is going to be on the right side as we look at it, it receives the oxygenated blood from the lungs, and then it pumps it out to the rest of the body. Now, we're going to use a simplified model of the circulation, and I'm going to give you an overview of the blood flow throughout our cardiovascular system using this. So first, we're going to go through the pulmonary circulation, and all the deoxygenated blood is going to be in blue, and all the oxygenated blood is going to be in red. So deoxygenated blood comes from the superior vena cava and the inferior vena cava. And these bring the blood from the upper body and lower body, respectively. And then they bring it into the right heart. Now, the right atrium contracts, and this pushes the deoxygenated blood through the tricuspid valve and then into the right ventricle, which then contracts, pushing the deoxygenated blood through the pulmonary valve into the pulmonary artery. And then the pulmonary artery carries the deoxygenated blood to the lungs, where it picks up oxygen and releases the carbon dioxide through a process of gas exchange. Now, the oxygenated blood then proceeds to the systemic circulation. And in this part of the cardiovascular system, oxygenated blood from the lungs that we see in red returns to the heart through 4 pulmonary veins and enters into this left atrium. This left atrium then contracts, and it pushes the oxygenated blood through the mitral or bicuspid valve into the left ventricle. And then once it's in the left ventricle, it contracts, pushing the oxygenated blood through the aortic valve and then into the largest artery, that largest artery system in the body. And from there, the aorta branches into all these small arteries, which then carry the oxygenated blood throughout all of the various parts of the body and the organs. Now, in the systemic circulation, arteries further divide into smaller arterioles and then into tiny capillaries. These are the microcirculation, and we're not going to talk about that much today, mainly because it's a full system on its own. The capillaries are actually the smallest blood vessels in the body. They go down to the size of less than the width of one red blood cell. The red cells have to deform to go through them, and these are located closest to the cells and tissues in our bodies and our body and organs. Now, in capillaries, this is where we have the exchange of oxygen, nutrients, and waste products between the blood and the surrounding cells. Capillaries then converge into these venules, and then they join the larger veins. And then these veins carry that deoxygenated blood back toward the heart. Now, the superior and inferior vena cava, again, collect all of that deoxygenated blood from the body and then deliver it back to that right atrium, like we talked about in the beginning, restarting this whole cycle. Now, each beat that we feel in beats per minute when we are measuring our heart rate has this procedure going down at all times, although the blood actually remains as continuous flow. This continuous cycle of blood flow ensures that all the oxygen and nutrients are delivered to the cells and tissues, while all the waste products, including carbon dioxide, are removed from the body. The heart's rhythmic contractions, we call a heartbeat, and the structure of those blood vessels contribute to maintaining the circulation throughout the body. So, as a structural entity on its own, if we mess this up with cardiovascular disease, we have actually messed up the foundation of our cardiovascular health and the delivery of blood to our tissues. So blood pressure is very, very important. All right, so I want to go through a little bit about basic blood pressure regulation right now. And physiologically, blood pressure can actually be described mathematically as the product of cardiac output and total peripheral resistance, where mean arterial pressure is cardiac output times total peripheral resistance. And since this is a simple linear equation, that any simultaneous change in cardiac output or total peripheral resistance will either increase or decrease blood pressure. Now, blood pressure is a tightly controlled variable that involves multiple systems that have feedback mechanisms which keep our blood pressure normalized at rest. But they also allow blood pressure to increase under times of stress. Now, when we talk about exercise stress, blood pressure goes up and it increases with intensity. This is a healthy response that matches blood flow to the heart and lungs and working muscles for increased performance. Once the exercise ceases, blood pressure falls back to normal and we kind of resume our resting homeostasis. Now, under chronic mental stress or distress, blood pressure is often elevated under resting conditions. This is an unhealthy cardiovascular response and is due to dysregulation of blood pressure by one or more of these systems that are normally involved in keeping our blood pressure in check. Now, for those of you that want to geek out, I'm going to spend a few minutes going through the very basics of these systems in our body and how it employs regulation to regulate blood pressure. So our blood pressure is a product, like I said earlier, of cardiac output and total peripheral resistance. Now, when we talk about cardiac output, this is actually the product of heart rate times stroke volume. So everything's linear. So anytime we increase heart rate or we increase stroke volume or both, we're increasing cardiac output. And if there's no buffering by the total peripheral resistance, then we will see blood pressure go up. So heart rate and heart rate contractility is controlled mainly by the sympathetic nervous system and the parasympathetic nervous system, where the sympathetic nervous system drives heart rate up and parasympathetic drives it down. And the sympathetic nervous system drives heart rate contractility, so the amount it empties per beat, and the parasympathetic nervous system will bring it down. The SNS and the PSNS work in balance with each other. And so we get what's called sympathovagal balance. And that's what your heart rate monitors, your Apple Watch and all those things are measuring when they give you heart rate variability. They're giving you an idea of what's going on with those two nervous systems. Now, epinephrine and norepinephrine drive heart rate and drive contractility through beta receptor activation in the heart. And that's why beta blockers are used a lot of times to lower blood pressure, because they will block those beta receptors that adrenaline and noradrenaline bind to, and decrease contractility and heart rate to decrease cardiac output and blood pressure. Now, we also have the kidneys involved, where increases in sympathetic nervous system activity drive sodium and water retention, as well as a number of different hormones. And I'm not going to go through all that right now. But basically, the kidneys also respond to stress. The sympathetic nervous system is our stress nervous system. The parasympathetic nervous system is our rest and digest nervous system. So when we're stressed out, we get increases in heart rate and contractility that drive blood pressure, but we also get increases in water and sodium retention from the kidneys. This increases blood volume, that then increases venous return through those vena cava that I talked about earlier that go to the heart with the deoxygenated blood. And what happens is this puts more blood into the heart, so we increase stroke volume to drive cardiac output up even higher. This will drive higher blood pressure. Venous tone. So this is the actual, this is the effect on the vena cava. If the vena cava becomes non-compliant because of stress, that's all we're going to talk about there, and increases in circulating adrenaline or epinephrine, then what ends up happening is we get increases in venous return, which then also complement the increased heart contractility. So stroke volume can go up, quite a bit and drive cardiac output even higher. And then on the other side of the coin, we have total peripheral resistance. This represents all of the resistance of all those little tiny vessels I was talking about downstream in the periphery. So within our organs, within our muscle, especially because it makes up 40% of our body mass. And what ends up happening here is we have a number of different ways that our body can increase or decrease TPR, or total peripheral resistance. So angiotensin 2, which we're going to talk about a little later, is a circulating factor that increases resistance by constricting vessels. We call this vasoconstriction. And at the same time, while this is all going on, we also will have increases in epinephrine that can drive increases in total peripheral resistance with it, which then drive blood pressure up. Neural innervation from the sympathetic nervous system decreases the diameter of these vessels, or vasoconstricts them also, which increases total peripheral resistance. If we have a relatively large increase in our red blood cell mass, this can be due to dehydration. It can also be due to androgen use. Then we have to take into account blood viscosity, or the thickness of the blood. And the thickness of the blood can really affect how well we can pump that around, and we need more pressure to do it. So that's why it increases blood pressure. And then finally, there's local factors that can actually increase resistance and decrease resistance in the local periphery. All these play a role. What I want you to take home from this is the common players of the stress nervous system, SNS, sympathetic nervous system, as well as circulating catecholamines like epinephrine or adrenaline, as well as things like angiotensin 2 that occur from the kidney, that occur when we have an issue with kidney function, liver function, heart function, or just dysregulation in general. All of these key players, when they elevate, will drive both cardiac output and total peripheral resistance and our blood pressure upward. So now that we have a grasp on what blood pressure is, what it does, and how it's physiologically regulated, I want to discuss the interplay between our biology, our psychology, and social life on cardiovascular wellness. So when we think about cardiovascular wellness, a lot of times we only think about these modifiable risk factors. And these include blood pressure, cholesterol levels, blood glucose levels, and body mass index, or how much extra mass we're holding on to that's not muscle mass. And although these are modifiable, there's a number of non-modifiable risk factors, like our genetics, how we picked our parents, how old we are, whether we're male or female, and whether we have histories in our family or previous histories of cardiovascular disease. These will also drive atherosclerosis. This is hardening and plaques in the arteries that we see in cardiovascular disease. But beyond that, a lot of times we don't think about things like our social environment and how that impacts all of these epigenetics. So how we turn on these bad genes, how we turn on the family history of cardiovascular disease, all these things happen because of the way we conduct business in our lifestyle and and what kind of social network we have. So lifestyle stuff like drinking alcohol, smoking, poor diet, stress, bad stress, and lack of activity, they all, we know, drive atherosclerosis through a number of different mechanisms. I can talk about those in the next slide. And we know that they also contribute to these modifiable risk factors. So how we deal with what our group that we deal with in our social life will have a definite impact on our lifestyle, which then will have a definite impact on our modifiable risk factors. And even though these are non-modifiable, they are epigenetic. So in other words, even if we have the bad genes on board, we can do something about it by actually controlling these variables. And then we don't turn on the genes that make us carry on this family history of cardiovascular disease. In the end, if we get these under control, we can circumvent things like atherosclerosis, which then decreases our propensity to get cardiovascular disease and cardiovascular collapse.